Okay, well, I think we're going to go ahead and get started. We may have a few more people coming in through the waiting room. Hello, everybody. My name is Dominic Tarpey. I am here at Langley Porter, and I'm a member of the committee that helps plan our grand rounds for this series, the Intensive Services Grand Rounds here at the UCSF Department of Psychiatry and Behavioral Sciences. So I'm very pleased today that we have Dr. David Kahn presenting on telemedicine and addiction. And just a housekeeping thing, please feel free to post questions and comments through the chat in the Zoom and get to them as we go along. So just to introduce Dr. Kahn, he is part of the UCSF volunteer clinical faculty. He's also an evaluator for ECT, conservatorship, and risk assessment through the City and County of San Francisco's mental health system, CBHS, and also does utilization review psychiatry with them. He's also the Chief Medical Officer at Bright Heart Health, excuse me, and also Medical Director at North Coast Substance Abuse Council in the Residential Treatment Program. And he's also a board certified psychiatrist in general psychiatry, forensic psychiatry, and also board certified in addiction medicine. He did his training at Northwestern in medical school and residency here at UCSF, and additionally completed the fellowship in the psychiatry and the law program here at UCSF. I could say much more, but I will leave it at that and turn the Zoom podium over to Dr. Kahn and go from there. So thank you very much, Dr. Kahn.
Thank you for having me. So let me just make sure this slide's being shared, and I'm going to have to hear an affirmative voice since I can't see.
It looks good.
Okay. So I'm here to talk about telemedicine for addiction treatment and how do we leverage technology to improve patient outcomes. And what I would say this talk represents is a distillation of my experience working within the digital health space. And I will have many slides that talks about comments where I feel like I can talk about sort of lessons I've learned over the course of doing this. From a conflict of interest disclosure, I'm an equity holder in Bright Heart Health, but this is not meant to promote or enhance the business. So as far as today's learning objectives, I want to talk about the value of data in informing treatment recommendations. What does telemedicine look like in multiple care settings? And also, what are the barriers to care that telemedicine is hoping to address? And of course, the idea of utilizing telemedicine to improve patient outcomes. So as far as my path, from 1999 to 2004, I was a psychiatry resident, and then did a one-year forensic fellowship at UCSF with Dr. Binder. From 2004 to 2005, I was the medical director of the San Francisco VA Intensive Outpatient / Partial Hospitalization Program. From 2005 to 2015, I was the medical director of the VA Opioid Treatment Program, namely it was a methadone program, although we used buprenorphine for medication treatment for opioid use disorder. That time frame, I think, is significant because in the beginning of my time at the VA, certainly working within the OTP, I was working with mostly Vietnam-era veterans where heroin was the drug of choice. At the time of my departure, we had started hearing about fentanyl, but fentanyl has become the majority drug over the course of time. So it was interesting having a front seat to the opioid epidemic. Although we say opioid epidemic, I call it the overdose epidemic, simply because that's the biggest problem we have, which is fatal accidental overdose. In 2015, I had started private practice. I'm sitting in my private practice office as we speak. And then from 2016 to present, I joined Bright Heart Health as a medical director as well as chief medical officer. So I've had a number of different practice settings also put in there. I spent some time over at Kaiser, so I've been part of academic centers as a resident. Federal government, I work still with the safety net system with community behavioral health in San Francisco. And now I'm wearing another couple of hats now. So that's the sense of my perspective from which I speak. Well, a lot of this comes from the startup perspective, and the question is, what is a startup? Some of you have been involved in a startup before, but a startup is a company in the first stages of operations. Typically, the people who fund the company, And it's typically focused on a single product or service. Now, with any startup, you don't usually have a fully developed business model, meaning that look, this is the business plan from soup to nuts, this is what we're going to do. And also startups, as I've learned, lack adequate capital, namely funding to get going. So why would you join a startup? Well, it's about innovation. One of the reasons that I joined the company was that I saw an opportunity to take good ideas and put them into action. Change is inherently rapid within a startup. Within every startup, what you got to do is you got to keep the lights on more than anything else. It's a change of scenery and pace. I'm used to what I call legacy medical operations, and joining something completely new was disruptive, uncertain, but at the same time, I found it to be a lot of fun. One of the things that I like to say is know your roles within any company. And the thing about a startup is that within UCSF, you have clear roles of who does what, where, when, and for what purpose, whereas in a startup, it's all hands on deck. So if you don't mind things getting a little bit uncertain and messy, that's what you can do. Now, some background about the company, which is important for you to understand. It started in 2015, and the mission is to connect experts with the medical care they need through telemedicine to do a full spectrum behavioral health disorders. It started as the eating disorder intensive outpatient program, and then we did substance use disorder, medication-assisted treatment, but we've expanded to a number of other things that I'll talk about later. Many of these expansions, for example, the expansion of chronic pain came out of necessity because those are the patients that we were seeing. And I felt that we had to address them appropriately and provide services for their level of need. And we have a focus of quality. We're Joint Commission certified. Having done lots of Joint Commission work at the VA, I thought to myself, why the heck would we want to get Joint Commission certified if we don't have to? But it's a universally agreed to level of quality. In addition to that, we're one of the first companies to get Joint Commission accreditation to do entirely telemedicine. But we've also partnered with other groups in order to do research and outcome studies. And right now we're working on an exciting NIDA Clinical Trials Network study comparing in-person versus telemedicine for the treatment of opioid use disorder in rural areas. Results won't come out for at least another 5 or 6 years, but one of the things I really love being is part of the research gathering in order to answer big questions. And one of the things that we found is we had to remove financial barriers very first and foremost. These are some of the people that we're partnered with, but the ones that I'm probably most proud of is Medi-Cal, simply because what I know is that safety net populations, people who are Medi-Cal recipients, are often uniquely burdened with problems of addiction and other co-occurring behavioral health disorders, but oftentimes are least likely to be able to have access or resources to treat their issues. This is one of my observation slides. The Veterans Administration did a very, very good job. I have nothing but good things to say about my time at the VA. I miss the people. I miss the patients too. What I don't miss is the system. It was the VA. And they treated veterans and limited non-veterans. In Kaiser, they only treated Kaiser members. And within my private practice, I had a fee-for-service model. But the thing that we discovered within the company is that third-party payment was absolutely critical. And talk about data leveraging our decisions. The first piece of data that we got is that people who were self-pay didn't stay in treatment. We often hear the argument a person will spend $50 to $100 a day for illicit drugs. Why can't they spend that on treatment? And I always find that to be a false equivalency, because when people are dependent, have the use disorder, look at great efforts to avoid withdrawal. Whereas when they're not currently dependent, they're not going to do that same type of hustling that would put them in inherent risks in order to pay for their own treatment. And also, as I mentioned before, the Medicaid/Medi-Cal space is wide open. They need services. There's a lack of access. Now, within the program itself, for those of you within substance use disorder treatment already, this should come as no surprise. There's admission, there's medications, there's treatment. Up front, we do a number of assessments to make sure that the person is appropriate for care, principally the ASAM assessment. But at the same time, there's many other data pieces that we're collecting. When it comes to medications, we do 70 to 30-day prescriptions, depending on treatment progress, drug screen results, and also prescription drug monitoring program, results. And the therapy is typically 2 sessions per week for the first 6 months and then 1 session per week thereafter. We tend to alternate individual as well as group sessions. And there's weekly symptomology checking, which will come up later in my talk. So people come in, they get medications, they get therapy, much like many other programs. As far as the therapy schedule, what we did is we took a partial hospitalization program, typical schedule, and basically decanted it out over the course of time. There's process groups, there's evidence-based treatments you can see here, such as DVT and relapse prevention. We also do things that are non-per se therapy, that talking about healthy relationships as well as coping skills. And everybody gets assigned to an individual therapist, which is largely optional. We ask that they work with the therapist at the beginning. And one thing that I think about is depending upon the addiction, the use disorder, what percentage of the variance will therapy help? If I think about opioid use disorder, 80% of the benefit is medications alone, but that still leaves 20% on the table where there's behavioral therapy and other things in behavior change to help somebody achieve their goals. On the stimulant side of the house, very little helps. So that's where we put an emphasis on the therapy, although I'm excited to say we've recently implemented contingency management, which is voucher-based incentives. Essentially, as people get negative drug screens, we can give them some type of financial equivalent remuneration in exchange for targeted behaviors. Highly effective therapy, works very well. I had some interesting experiences, which I'm happy to talk about later. And when it comes to the comprehensive treatment, medication, counseling, case management, peer and recovery support, they all work together. As we all know, with substance use disorder, there's no one thing that controls the entire variance of somebody's lives. And the other part of substance use disorder is the most common co-occurring substance use disorder is yet another substance use disorder. And the co-occurrence of trauma, adverse childhood experiences, as well as other psychiatric disorders is extremely, extremely high. So we got to take care of the whole puzzle. If you look at the case management side, issues of employment, housing, family services, primary care is a really critical one. And look, there's 4 reasons that people come into treatment: liver, lover, livelihood, and the law. Essentially, they're all consequences that leverage somebody into treatment. And we have to address not just the use disorder itself, but how do we ensure that the person is properly equipped to deal with either consequences or the stressors in their lives that are driving continued use. Now, if you come to our website, you can click on it. We set up a virtual clinic. And in clicking on that website, and you can do it right now, essentially what it creates is it mirrors the initial clinic experience of people walking in. They're met courteously, and then they can sort of get the services that they need directly via Zoom link. So a virtual clinic is something that I thought was important in order to kind of mirror the in-person clinic experience. Now, with groups, like many virtual groups, it looks like the opening sequence of the Brady Bunch. You see a bunch of heads on the screen, but at the same time, the group experience is quite powerful for patients. I see very similar group dynamics to the groups that I recall from being at the Veterans Administration. There's also unique group dynamics that I'll explain in a little bit. Oh, and the other part that I would say is that group disease management, where we have a therapist as well as a physician in a room, is our modal form of treatment. It's effective. It allows for more people to be served at once. As I mentioned, the usual group dynamics occur, but there's also different ones as well. For example, the dynamic where 2 people conspire to return to use, also known as relapse, that doesn't occur simply because people are distantly located. And when it comes to the process of change, the main dynamic that I see is identification. If a person can sit in a room with other people similarly situated, that's the point where people are authorized to change, meaning that they could sit in a room and say, hey, look, I belong here. I'm one of these people. And when it comes to peer support lent by groups, it's tremendous because, as you know, a therapist, a physician can tell the patient what to do or what their observations are. But it is so much more powerful coming from the other, participants. And what we do is we incorporate different aspects of care to amplify a single approach. I I'm a believer that counseling for medications for opioid use disorder is critical, despite research showing a marginal benefit at best. In our research, our data, people engaged in counseling show significant benefit, and counseling is part of the medication management itself. Now, when it comes to symptomology tracking, we collect a number of different data pieces, and the data pieces that we collect are different depending on different cohorts. If somebody's part of a pain cohort, and they can be part of multiple cohorts simultaneously, we're looking at pain, enjoyment, functionality. Whereas when it comes to substance use, we're looking at substance use disorders. But by tracking symptomology and having a consistent report on it, it allows a multidisciplinary team that's distantly located align around what is the purpose, what is the treatment plan, medications, therapy, what are the issues that we're addressing. So symptomology goes a long way. This is another lesson I learned from the VA too, is that as part of VA leadership, I was often asked to collect data on very short notice with little clear indication, why am I collecting it? And if we would ever ask VA Central Office, okay, what did our own data teach us relative to other VAs? There's often a non-response. And so when it comes to data collection, I only insist on data collection that is actionable or necessary. For example, an actionable piece of data is, where's their symptomology going? Does that mean that we have to change something with the treatment plan? Some stuff is necessary, for example, consent and things like that to treatment. Now, when it comes to observations about data, data is extremely, extremely powerful. We often have a sense of working with patients that we're collecting data, maybe BDI, BAIs, or something like that. But when you keep the data and you keep it consistent, artificial intelligence and machine learning can provide numerous insights. What do I mean by insights? Well, the things that we found out is that pain is a predictor of early dropout. We used the BAM, the Brief Addiction Monitor, developed in the Veterans Administration, and they asked the question, how's your pain from 1 to 4? If you have a 4, that means you have daily severe pain that interferes with your functioning. And if somebody had a pain scale of 4, people would have an average length of stay of about 62 days, not very long. We learned that self-pay is not sustainable. And one of the interesting findings is we have certain patients who would call us or contact us repeatedly through the clinic asking, where am I supposed to go? What am I supposed to do? And we thought that these were patients who were not getting it. Well, it turns out that people with more frequent contacts for all reasons were better retained, meaning that they were engaged in the process. And one actionable piece of information that you should take away from this is that an average childhood experience, most of you are familiar with the ACEs, if an ACE score is greater than 1 or greater than 0, actually, if somebody has 1 or more ACEs, it actually predicts a delay in improvement. Meaning that if somebody has an ACE score of anything, essentially we can see a 90-day delay before they start to show any improvement. Well, why is that good news? Well, because patients, when they're working in treatment, often feel like they're struggling. And we can tell them, they say, look, our own data says like it's going to be a struggle for some time. So essentially they get a sense of where they are in the treatment process before expectations of improvement come. And the other part of these types of things is that, for example, with pain, one of the things we're able to do is automate a recommendation that they be referred to the pain program if we see that score of 4 instantly. So it's almost like an opt-out menu for the clinicians. So it's not that clinicians have to get the data, think about it, and make the referral. We can start to automate processes that are highly predictive of dropout. Now, one of the things I've heard over and over again is the idea of no wrong door when it comes to addiction treatment. Whether you're in the ED, primary care, police station, or someplace else, if you've got a problem with the substance use disorder, you should get access to treatment. And for many, many years, I was part of the problem in running an opioid treatment program and sort of screening and deciding who got in or who didn't. I'll plainly admit that. But essentially, the research shows that if you have awareness of healthcare services throughout the natural networks, it'll allow people to get into care. And so the optimal intervention opportunity is when somebody's ready, no matter where they are at the time. And you'll notice emergency departments, law enforcement, legal drug courts, corrections. These are times when people are in obvious trouble. But there's other places, for example, the internet or through social services, when they're seeking help that they can potentially get into care. So when it comes to each of these settings, it's a place that we've injected ourselves into because that's where the patients are at. We've done telemedicine for the emergency department. They can call directly. Although the best option is to give an expert and start a person on medication such as buprenorphine in the emergency department, leads to much higher retention than just giving somebody a referral. Although if we can get a referral through the tablet, people are much more likely to connect with us because they've already had the experience of getting registered, interacting with staff. One of the things that I've found critical with the staff is that they need to be trained in motivational interviewing, especially the frontline staff answering the calls. Patients will call, and the person who's sitting next to them that we cannot see nor hear is the family member says, you got to get into treatment now. Now, one of the things that I've been doing is peddling the program in the beginning. And when I sort of assembled the program, it was a program that incorporated all of my past experiences, meaning that I would offer counseling, we accept Medicaid, we have on-demand services, we're available 24/7. And in some ways I joke that this program is a representation to eliminate all the mistakes I've seen in other places, including mistakes I have plainly made myself. And the interesting response to partners is, it sounds too good to be true. Wait, we could do all these things and Medicaid will pay for it? It sounds too good to be true. When I started presenting data, that's when the relationship shifted from we don't believe you to how do we sign up and how do we get you as a partner to service our patients. I'll talk about data later, but when we have data better than national averages, it often gets questioned, but it's when we interact with the payers, the Anthems of this world, the Blues, when they start to see their own data being reflected, that sort of increases the likelihood of referrals. Again, you can sell something as much as you want, but data really speaks above all. So when you think about program design, sending it out, make sure that you have some data attached to it as you're trying to expand services. Now, primary care settings, they face challenges with opioid dependent. I mean that in the strictest sense, that patients with dependencies upon opioids, not necessarily use disorders, but essentially they, at least patients and providers feeling frustrated, meaning that they were the ones who prescribed, they're getting confusing guidance. Do we taper patients? Does the person have a use disorder? And essentially working within primary care is a critical piece of things in my view. They're where the patients are at. That's where the majority of patients get their medications for those who aren't using street access to opioids. And primary care is frustrated with this. That said, I talked with one of my friends from medical school, and he's the head of a very large primary care group. And I asked him, Doug, what about the problem of opioids? And what his response to me was, I thought was instructive. He basically described it as one of many gaping knife wounds in the side of primary care, which made me realize really quickly, like, look, primary care's got a lot of stuff going for them. They have a lot of requirements, and the opioids that we see it as a problem, it's one of many problems perceived by primary care. We've made some approaches to health plan members. So if somebody has more than 100 milligrams of morphine equivalents, well, let's talk to the PCP and the patients regarding potential solutions. We use the Zedler overdose risk index, so we can target members with high overdose risks, and there are indicia of that, such as ER visits, inpatient hospitalizations, so on and so forth. When it comes to women who are pregnant or might become pregnant, we focus on the recurrence of neonatal abstinence syndrome as well as NICU utilization. And of course, residential treatment programs, trying to get people in treatment on medications while they're in the residential treatment program. So these are some of the things that we've talked about with the health plans. Now, here's a case study of New Mexico. For those of you that know New Mexico, there's maybe two large cities, Santa Fe and Albuquerque. Otherwise, it's a very, very rural state. As we went into the New Mexico area, what you'll notice is heat maps that aren't necessarily concentrated within the cities. We get a pretty standard age distribution, men as well as women who are accessing care. But the really fascinating thing that I see is that multiple generations come into treatment simply because there's a lack of access. And when they hear good things from other family members, they will come in. Some of my observations about partnerships is word of mouth still remains the best form of advertising. I can give as many presentations and talks, but but the word of mouth from other people who've had a successful experience makes the biggest difference in coming into care. People are indeed interested in treatment. What the data show us is maybe 10 to 20% of people with use disorder make efforts to engage in some type of treatment. And the idea that I want to promote is trying to get in as quickly as possible. And as I mentioned, in San Francisco, a very rural area that you practice in, there certainly are different care settings that people can see, but in more rural areas, we find ourselves treating multiple generations. In fact, we have families with 4 generations in treatment, from grandparents, great-grandparents, grandparents, parents to the kids within the same treatment program. Now, what about emergency departments? So one of our first partnerships was the Community Hospital of the Monterey Peninsula, and we were able to implement treatment, which looked like the EDs starting buprenorphine and then referring to the program. We implemented within less than 30 days. And when I say implementation, what do you have to do in the emergency department? You have to train the staff, wall posters and brochures, handouts, those types of things. And within the first month, we had 25 interventions and referrals. 100% of people made their first appointment, and 95% were retained in treatment at 30 days, which was a significant improvement on a study using the same design at Yale. They did about 73% of patients within treatment at 30 days. But emergency departments are fascinating places. I don't know if there's any ED staff on this call. I'm guessing not. But an ED is where everybody is. You have the patients, you have their providers, the physicians, nurses, social workers, other staff. That's also where the police are. That's where EMS is. That's where everybody kind of collects in the emergency room during a time of crisis. And so when it comes to working with the emergency departments, it tends to be a good place because somebody could have come in for an overdose event. There's some EDs that, if you're familiar with the ED Bridge program, or actually it's now called the California Bridge program, I highly recommend that as a resource, because what they're trying to do is implement medications for opioid use disorder as quickly as possible, starting in the ED. I mentioned primary care. We worked with Hill physicians. We were implemented in less than 7 days. We trained staff, wall posters, and things like that. And we had 25 plus interventions, meaning patients referred in 5 weeks. And the part that we were looking at is assisting patients with high levels of morphine milligram equivalents and patients on full agonists more than 6 months. So again, we're trying to address the problem, because when it comes to primary care providers, what I can say from the medical legal side is they're the ones who get accused of excessive prescribing. They're always worried that somehow something untoward is going to be happen, despite them practicing good medicine. And our role in working with them is to help assist with the patients, in addition to helping to assist with the patients. Sometimes we do consultations that basically we tell the primary care provider, you're actually doing the right thing. So, and of course, one of the things that where physicians get in trouble is they said, hey, you failed to consult to assess your treatment plans. And that's a service that we can provide fairly easily during the usual and customary course of care. Now, one of the things that I'm particularly proud of is that there was a research study that came out a couple of years ago, and it showed that people who had an overdose had a 10% likelihood of death, mortality within a year after the overdose. A certain percentage die of the initial overdose, but many more people die of repeated overdose, as well as all-cause mortality, homicides, natural death, and those type of things. So an overdose event is, the clock is ticking. 1 in 10 patients are going to be dead within a year. And what I thought about is, like, how do we get to these patients? Well, we partner with Marin County to surveil the EMS services and make efforts to reach out to the patients to try to get them in care. The graph on the right is the number of cases reviewed. The green is the number of people whom we were able to get a hold of. Now, most of you know that if somebody's had an accidental overdose, you're not going to see them. Mostly, they're not the ones who are calling emergency 911. But what we do is we get the natural language voice transcription. We call back the number and make an effort to reach the person who had overdosed. And this effort is going to be replicated in a couple of other counties. And I'm particularly proud of it. Though we reach only 10 to 20% of patients, about 50% of those patients do accept a referral into care. And as we track the overdoses over the course of time, something interesting sort of occurs. we can notice by Marin County, notice it's in the Marin County is probably two different places. On the west part of Marin County, there's West Marin, very rural, very farmland, versus Eastern Marin, it's the 101 corridor. And not surprisingly, the number of overdose instances that we're talking about tends to do more in bigger cities or places with greater population density. This is a location of the different incidences. But the thing that I've really learned is that sometimes we'll get the same person calling 3-4 times over the course of a couple of months. And when people call 911 for an overdose, 50%, 50, never make it to the emergency department with the opportunity to intervene. As I mentioned, we reach about 10 to 20% of suspected overdoses. This is a high-risk population, and this is really a first-of-its-kind type operation, something I'm deeply proud of because it's reaching the people that I worry about the most. I've said before that I don't worry about the patients that I'm treating. The patients I'm worried about are the patients who are not in care. They're the ones whom I'm most concerned about. Now, when it comes to the data and the information, what does it tell us? I keep telling you data is important. Well, what do we actually do with that information? And, our strategy is to have a real-time dashboard of patient symptomology. And when I say real-time dashboard, I mean real-time. If a patient puts their survey in earlier and it changes the information that's there, it'll show up. We also get a real-time population health analysis, meaning that we look at the population health and we can break that down by individual patients, we can break it down by communities, we can break it down by health plans. And so when you ask the question, what's going on with the people that we're working with, having data can answer those questions, that can answer those questions very quickly. I mentioned the Zedler Overdose Risk Index that helps us identify who patients are at high risk based upon assessment. And retention risk analysis is something that helps us reduce patient abandonment. We have predictors of the patients who don't stay. I mentioned pain. I mentioned self-pay. These are all predictors in which they're going to leave. We've had more recent analyses looking at personality assessment. It turns out people who like to run their own program oftentimes will not stay very long. And so we have to work with them and provide optimal intervention strategies based upon what it is that they want. And we're also looking at real-time admissions data to reduce barriers to entry. Well, what does that mean? Well, for all things in a health sort of a treatment, from a treatment perspective, there are a lot of pieces of customer service that make a difference. How long is somebody waiting on the phone? Did they drop off? Have they received the text message? Will we mail urine drug screens to them? Have they had the opportunity to receive that drug screen and process the test? So a lot of it depends upon looking at real-time data to see what is going on, because if we notice backups and call volumes or logs, then we can sort of staff it appropriately. Now, this is relatively recent data, and we looked at 30-day retention. It's about 81%. About 90-day retention is 56%, which is below our goal of 75%. As we dig into it, this is the people who are dropping out are primarily the patients who identify as having chronic pain. Now, we've moved on this and the data have gotten better, and within developing a chronic pain program, we fence the patients off from the traditional substance use disorder program, and we use a very different set of language. So for example, when it comes to opioids, we don't use the word overdose. What we say is that opioids plus other medications or opioids plus alcohol can cause an adverse reaction or allergic reaction, which could potentially cause you to stop breathing. So what I've just talked about is overdose risk, but I haven't used that word at all. And in talking to patients with persistent or chronic pain, what we're trying to do is use the language that they agree to. Now, as we break it down, is it an addiction clinic that's referring drug court to FQHC or primary care clinic? Again, the chronic pain issue shows up here. And when it comes to the primary care referrals, the level of ambivalence demonstrated by patients is quite low, meaning that they think they're getting the right treatment, and the recognition of risk remains below the mean as well. as compared to, say, an addiction treatment program, an opioid treatment program. Patients agree that they need treatment. And so what it is that we need to work with the patients to speak the language that they speak and give them the interventions that they care about, such as addressing pain, such as giving them multidisciplinary pain program. One of the things with the pain program is we're trying to get away from the narrative that medications are the answer for all sorts of pain, because that's often what the patients sort of think about. Hey, it's just about the medication. I need the right combination of medications. Where we're introducing more active pain management strategies, such as mindfulness-based interventions, behavioral activation, getting them peer support, other pieces, physical therapy, and of course, if an assessment that we do via telemedicine suggests that we need an intervention, such as an injection or potential surgery, we can refer them to local sources that can do this. Now, if we look at retention, or as we look at percent negative drug screens, this is for the addiction treatment population, and 84% of patients are negative for opioids at 30 days. And 93% test positive, just 10 test negative for opioids besides buprenorphine at 90 days. These numbers are, I would say that compared to community standards is pretty darn good. If we look within OTP populations at 30 days, perhaps you'll get 60% of patients who are negative for illicit opioids. And at 90 days, that number may improve a little bit, but typically not a lot. So to the extent that we're being effective with both medication dosing as well as the counseling, I'd like to say that we are, and certainly the data from our own drug screens backs it up. One question that I often get asked is, how do we do drug screens? Well, what we actually do is we actually physically mail drug screens to the patient, namely they get the packets. And within those packets, I can show it to you perhaps later in the Q&A, but we have them provide a specimen. And within that specimen, we can look at whether or not the specimen is negative or positive based upon just showing it to the camera alone. Now, people are often critical and say, hey, they can always substitute the specimen. Well, they certainly could, but they'd have to have a specimen ready that's between 90 and 100 degrees Fahrenheit and also have the built-in control of buprenorphine present. And the other piece of things too, if somebody produces a urine cup that's desperately old, you can definitely see that on camera. So when it comes to drug screen results, I believe in the results that we're getting. Now, if I look at specific quality measures, so the question is, all right, so if we look at the BAM factors, such as the brief addiction monitor, what I like about the BAM is that it shows actual use itself. It shows protective factors as well as risk factors. And in sort of pulling apart all those different constructs, it's both measurable and actionable. If we see somebody with low social support, that's something that can be a risk factor, but it's something that we can potentially modify through the course of our treatment. If they have high levels of pain, it's a risk factor, but it's something we can address through addressing pain. When we looked at kind of pre and post, what we found is an improvement in alcohol consumption of about 86% of patients, drug use, 97%. It says drug abuse, but that's a term that they use. I don't like it. Drug use is 97%, alcohol binge is 98%. If we look at the scores, and it might be hard to see on your side, but in the sort of left-hand side is alcohol consumption. The second to the left, binges. Third, drug use, opioids and specific, sedatives, cocaine, stimulants, cannabis. And what we found pre and post, there were significant reductions over the course of time. And on the far right-hand side, you can see a Kaplan-Meier plot showing the probability of improvement in any illicit use and prescription or misuse of prescription medications over the course of time. And that Kaplan-Meier graph is significant in that we've been collecting data since the beginning. And what we hear in most types of substance use disorder treatment is you want to retain people for at least 90 days. Well, 90 days is fine, but you're still not at the full potential benefit yet because the benefit continues to rise over the course of time within treatment. At least that's what our data says. If we look at risk factors, there's a large percentage of patients improving a number of risk factors. For example, cravings and withdrawal, negative social support, family and friend arguments, primary psychiatric measures, anxiety, depression and anger, physical health and sleep issues, which tend to be a bit refractory, part of the reason that we've started a CBT-I program, cognitive behavioral therapy for insomnia. And if we look at pre and post test scores, what we see is drops in the overall risk factors. And if we look at the on the right side, cravings and withdrawal by duration of follow-up, again, we see improvement over the course of 90 days, but that improvement sustains out to almost 9 months. So people continue to get better over the course of time. So oftentimes, the mistake that I see with treatment programs, or at least addiction treatment as it's packaged, is going to residential treatment. All your problems will be solved. Well, that's like arguing addiction is like pneumonia, therefore you need penicillin to address it. No, it's something that requires chronic and repeated management over the course of time. Now, when it comes to protective factors, abstinence, confidence, positive social support, work at school, volunteering, so on and so forth, there was improvement in the protective factors. So in the middle graph, you want to see the lines go up. And if we look at the Kaplan-Meier looking at improvement in abstinence confidence, that improves over the course of time. But again, we start to see a peak out somewhere around 9 to 12 months. And one of the most common things that I see in patients is this sort of sequence of events. The first thing that they notice is that their withdrawal, they start to feel physically better. The second is that we see that cravings then decrease. And then the third block of things that we see is that people become more confident in their ability to maintain the patterns that they want to maintain. So you see that sequencing. And as I mentioned, for patients with adverse childhood experiences, that there's a delay. There is a delay in improvement. And as we sort of have that delay go forward, we work with patients to say, hey, stick with this. We know that you're feeling like you're struggling. But over the course of time, trust us when we say that things will begin to improve. So when it comes to advanced care delivery, individualized care, addiction is not just addiction. Addiction is addiction plus physical health, pain management, co-occurring disorders, and activities of daily living. The numbers that I show you are as we sort of address the different things like physical health, we can push people from an average of 23 days up to 82 days. As we address the co-occurring issues, pain management, co-occurring psychiatric disorders, we can then increase that up to 139 days. So those are numbers pulled out of a hat. These are numbers that we ourselves found as we start to address comorbidities, how much things will improve over the course of time. So I'll finish my prepared talks, but I look forward to the conversation. As a startup culture, it's very fast-paced. Change is constant, and you have to balance change with both employee needs, patient needs, also what is realistic. I come up with the best ideas in the world, but at some point we have to implement them. COVID-19, as we all know, has accelerated the growth of telemedicine. Remember, I started doing telemedicine in 2016 in a meaningful way. Well, that's not true. I did do telemedicine when I was involved with the San Francisco VA, and I would say that the Veterans Administration is one of the early leaders in the promotion as well as the acceleration of telemedicine. But COVID-19, not surprisingly, forced everybody to go from the clinic onto our computers virtually overnight. Mentioned digitally native platforms are hot investment opportunities, in large part because not so much that for Bright Heart Health, but what I'm saying is that there's lots of money floating around in this space. And so that's one thing that people are thinking about as far as like why participate. When it comes to program development itself, know your roles. Look, I will plainly say I'm the ideas guy. I am terrible at implementation. Now, I happen to be lucky to have colleagues who are very good on the implementation side. So a lot of these things that provide the ideas, when the implementation gets taken over by somebody else, I am quite happy to see that. And finally, I would say that the group that I work with, it's a distillation to avoid the mistakes I've seen in other systems, where patients are prevented from getting access, when patients cannot get the treatment that they need. And so developing the program that I develop, I'm trying to provide access to all patients, good treatment, because as much as I prize individual health, mentally, I'm a public health guy. I believe in improving the public health as best as we can. And the goal that I have, particularly for patients within any addiction treatment program, is there's the first lasting and enduring goal, which is fatal overdose prevention above all. When I say fatal overdose prevention, I'm talking about preventing people from having fatal overdose. As we know, during COVID-19 in 2020, more than 90,000 people died of an overdose, which is a stunning number. It's an almost 20% increase over the previous highest numbers over in 2018. 2019 showed a slight decrease, but 2020 was a very bad year for overdose. And in addition to that, what we're seeing is a good chunk of the overdoses are related to stimulants like methamphetamine and cocaine. And from an equity lens, the people who are having increasing stimulant overdoses are Black, Indigenous, people of color, people within the safety net. And so trying to getting patients access to needed treatment, we're not just treating the patients who can afford it. We're not just treating the patients who are Caucasian. We're treating all the patients who potentially can benefit from these services. So with that, I will end my prepared talks. Feel free to post any questions or comments in the chat box, and I look forward to the conversation. Thanks so much.
Thank you, David. Really excellent overview. Just to get us started, I have a question. If you had a magic wand or a wish list of things that you could, barriers you could remove or enhancements to the technology or other aspects of telehealth and the treatment of addiction, what would they be in terms of the wish list?
Yeah, so I would say the wish list, one of the biggest things in my wish list is continuing the rules as we have them right now. What I mean by that is with COVID, they've suspended they've enacted the public health emergency rules around the prescription of medications without requiring a face-to-face assessment. Essentially, to start somebody on buprenorphine or another medication besides methadone for opioid use disorder treatment, you can do it as easily as talking on the telephone. Now, there are two bills in Congress. There's the TREAT Act as well as the Stop Fentanyl Act that would make the current conditions permanent above all else. So my first wish was, let's keep things the same here so we can make access really easy. In the early days, we'd have to go through great lengths and certain gymnastics in order to get people into care. Namely, we have to have that face-to-face. So that's the first thing. The second thing I want people to know is that there is, through the Federal Communications Commission, ways that the federal government will subsidize getting a person access to broadband, essentially. And it's less of a problem in San Francisco. I would say that even amongst the homeless, working with people in homeless service type areas, what we find is that with homeless services, most people have internet enabled devices, but many people don't have data plans. And so trying to subsidize that makes sense. And I think that understanding for most programs, we are a harm reduction program. We aren't per se an abstinence oriented program. Abstinence is often the result that we achieve, but at the same time, again, I said before, the first, last, and most enduring goal of addiction treatment is the prevention of fatal overdose. So trying to get people away from a pure abstinence orientation, I think, is really critical because the lessons I've learned in treating patients is that it takes time for them to change. I'll tell a story of a guy named Joe, not his real name. He was a veteran that I worked with within the opioid treatment program, and he used crack cocaine from 1985 to 2010. How did I know he was using crack cocaine the whole time? Well, he told us so, and he tested positive, and it was something that he wanted to change. Now, at the ripe old age of 57, I finally went into one of his many hospitalizations and institutional visits and said, Doc, I'm sick and tired of being sick and tired all the time, which I said to him, Joe, I've heard that story before. And he came out and tested negative the next week. And I thought, whoa, this is different. And over time, he would continue to test negative for the duration of my time at the VA. And I asked him, look, Joe, is there anything I could have said to you 5 years earlier when we started working together that could have changed things? He said, no, Doc, I appreciate everything you've done. I feel like you've done a lot to sort of keep me alive up until this point, but really the decision was mine to make. And in that lesson, the idea behind persistent chronic care is the message I want all people to think about as you're working with patients, because requiring people to be a certain way, such as abstinence, such as well-behaved and those type of things, isn't what I consider to be best care. But thank you for that question. I mean, these are some of the many ideas that I would love to see, which is let's keep things the way they are, even after COVID, so quote unquote, goes away. Let's see. So there's a question in the chat. Do you have how many clients you've worked with at Bright Heart, and what's the average sense of the people who are in care is? As far as the total number of patients that we have, right now, I think we're in excess of 4,000 current patients. We're growing very quickly because if I showed you a growth curve over the course of the pandemic, that growth curve would be pretty steadily upwards. As of last month, we've just exceeded 500 new patients per month. As far as the number of patients per counselor, for example, the counselors, we use certified addiction providers, mostly marriage and family therapists. Each marriage and family therapist, I believe, we're trying to target no more than 25 individual patients, but they also work in the groups too. And typically they have their own patients in the groups, but within the groups, they also have patients whom they don't directly work with in managing the treatment plan. For the physicians, that number tends to be a bit higher. The DEAX waiver allows us to go up to 275 patients per physician. And but we don't have, I think our physician with the most patients has about 130 patients at this point in time. So there's the capacity for growth. What's considered to be full really depends. I'll say one thing among startups is like employment turnover, like people leaving for other reasons is significant. And that's one of the things that we're trying to do is help people stay within the company. As anybody who's a hiring manager knows, hiring and retaining is really one of the keys to keeping costs down. And so, but that's one of the things is people come in, they try us out, both the patients as well as the staff, and sometimes they leave. So sometimes we have, relatively speaking, higher numbers of patients per staff, but we try to keep those numbers consistent. And if it gets to the point that we're getting full, we're making efforts to hire more people. Some comments I'll make for the physicians when it comes to, not asked, but not really a focus of this talk, but when it comes to physicians and doing assessments for opioid use disorder. It's a question of, is there a nutritional aspect of the program? Yes. Since we started as an eating disorders intensive outpatient program, we have certified nutritionists. And we don't think about it just purely for the patients within the eating disorder cohort. We think of nutrition for everybody. Is there some opportunity to examine somebody's nutrition? Is there an issue of food insecurity? Is there many other things that could potentially impact the way somebody's doing? I think it was the great philosopher Jacques Lalonde who said, "What are you? Well, you are what you eat." And therefore, I think it is a critical part of the program, having nutritional services. Let's see, Dr. Borsari, how's treatment fidelity monitored, especially for treatments such as DBT, CBTI, and MI? Great question. So one of the things that we do is that we use everything via Zoom, and we have natural language voice transcriptions, and we hold on to all of the recordings. And so when it comes to treatment fidelity, we can actually do that by using it against, we've worked with consultants, and you, Brian, would probably be better to say, but we can actually look at statements and to measure treatment fidelity. So we automate those things around treatment fidelity, around CBT, as well, particularly MI in particular. Now, what we see is that physicians tend to use fewer MI skills, which is not surprising. They're often targeted towards medical intervention, whereas the sort of upfront contact as well as the therapists are much more adherent to MI. So what we do is we use computers. We get the natural language voice transcriptions. We're getting to the point where we can get vocal inflection in there to sort of run more than just the actual templates themselves, but we're essentially farming data over and over again to figure out exactly what that's going to tell us. For those of you with exposure to artificial intelligence, it's a bit unsettling, meaning that it's a bit unsettling in that the machines tell us, hey, look, these are predictors, but yet they can't tell us why these associations are there. Some of the associations I can reconcile, for example, the pain equation. Look, I get that. I understand why people with persistent pain tend to drop out sooner. At the same time, utilizing the data sets that we have and also natural language voice transcription, we can check not only just fidelity, but we can do things like that. We talk about doing tobacco cessation. Are we doing experts? Are we doing suicide assessments and screenings? And the other nice thing about having a natural language voice transcription of the recording is we can take the charting off of your desk, meaning that we send it to certified medical transcribers. They look at it and they put the note out there for you. And then you just have to review and sign it instead of writing the whole note itself. Am I familiar with anything similar for alcohol use disorder? Yeah, there are programs out there. I don't have as much familiarity with them. A lot of them focus on either the Sinclair method, meaning that taking naltrexone before drinking. There are formalized treatment programs, although most of them that I've seen are dedicated towards the commercial space, people with commercial insurance. And I'd say our principal specialty is 80% of our patients are Medi-Cal. Another question, is there an in-person physical examination? There used to be. We used to have the in-person physical examinations, but when it comes to physical exams at this point in time, we're relying a lot on the primary care providers. And another question is, do you get permission for the patients to do transcription? Yeah, we get that up front. We tell them that, look, we do record a lot of this information. We do record a lot of this information and we use it for our own internal data purposes, but it is medical information. You know, those recordings should be accessible to patients. And what's really nice about them is, you know, I haven't had a patient ask for their recordings, so we can provide them technically if we want to, or at least the transcripts of the recordings that we have. It's all part of the medical record. Do I encourage 12-step involvement? Absolutely. The way I personally think about 12-step is this is a form of support that I cannot provide myself. You know, it's 24/7. It's a peer support service. It has, you know, there's a common mission and a goal that unites with rules as with the steps as well as the traditions. And I think it's a critical piece of many people's recovery, though I don't see it as absolutely necessary to get the peer support. And the telemedicine companies will become increasingly bureaucratic and problems because the business people start dictating to clinicians. Well, that's part of the reason. I mean, I'll just say from my company perspective, we're an employee-owned for-profit company, and what we've tried to ward off venture capital money in large part because once the business interests come in, we start to lose control. I don't want to lose control at this point in time. So venture money, they're looking for profit quickly typically, and the timeframes for profit are on a much more accelerated scale than we can actually produce good product, meaning effective treatment services for as many people as possible.
Well, we are almost at 2 o'clock, so maybe we can finish with those great questions and a really great talk. Thank you very much, everybody, and thank you, Dr. Khan. Bye-bye.
Thank you. Bye now.